Hi, everybody, and welcome to Beyond Telehealth and Telemedicine is Medicine. And I'm your host today, Dr. Lisa Finkelstein. It's been a little bit, and we have a special guest today, Dr. Chevon Rariy, and she is going to bring us forward a year and a half and talk about what's been happening over the last, I'm not going to use the term post-pandemic because we are still fully in COVID central. So Chevon, let's introduce yourself. Tell us your new title, where you practice, what's your specialty, and then explain what your new titles mean.
Of course. So thank you. Thank you, Lisa, so much for having me. I'm excited to be on and to share my experience in telehealth. As Lisa suggested, I'm Dr. Rariy. I'm an endocrinologist by training, and I work at Cancer Treatment Centers of America. I'm based out of our Chicago office. Um, I focus on endocrine oncology, and I oversee and lead our virtual health program. So I'm been recently appointed the chair of our virtual health department and the vice president of clinical products and innovation. So it's an exciting time, I think, for us all to really those of us who've been in this space for a while, it's the silver lining, if you will, of the pandemic, and really has allowed us to redefine and transform healthcare um, from my standpoint for the better. So it's created these opportunities.
Why did you get involved in telehealth in the first place? And that led you to these positions. Who would have thought that somebody who was board certified in internal medicine and endocrinology would end up being the head of a telehealth department and innovations? It's sort of, I can't believe it myself. So what
Yes.
made you get into telehealth?
So it is, I think, a very exciting story. What made me get into telehealth was, I'll take a step back actually, and what brought me to the concept in general. So I have to say that I grew up poor. I grew up in a very poor household. My parents divorced very early, and it was my mom and three kids, and she had to provide for us and take care of us. And so you can imagine we had a number of problems that we faced, and we didn't have the means, the monetary means to buy solutions. I would say today you can buy a solution, So for myself, we had to innovate, we had to create solutions, we had to build, we had to model, we had to make do essentially. And so I fell in love with the idea of creating solutions. I fell in love with innovating with what I had to, create a process that improves. And that, I think, very much played a role in my interest in telehealth and my interest in innovation and problem solving. So when I was in medical school, graduated from Harvard Medical School, I was in the West Roxbury VA. And we were, doing our general rotations, and I was rotating through endocrine actually, and we completed a telehealth visit where the provider was able to provide care through telehealth to an individual in a rural community. And I found that fascinating because the problem was and has always been access to care. I've always been passionate about providing access to quality health care for those who don't have it or couldn't afford it. And what a way to provide access to care to patients who didn't have it. Telehealth just blossomed in my mind and really stuck with me. Continued to have a keen interest in it throughout my medical school and residency, and then fellowship. And so stayed very much involved in much of what telehealth could offer and how I could play a role in bringing that as a solution to care.
Well, I mean, so that's very organic, and my experience was very similar because I had to figure out how to access my patients in rural Wyoming without driving 150 miles or flying on a plane,
Yeah.
which I did for about 12 years. And so telemedicine was one of those, moments of there has to be a better way. And then, as you also said, the silver lining of the pandemic for us was the momentum of telemedicine, right?
Absolutely.
So let's talk about what's one of the most pressing lessons that you've learned in the last year and a half throughout the pandemic?
Absolutely. So I think one of the most pressing lessons that I have learned is kind of a compilation of a number of them. So despite the fact, so telehealth is absolutely a tool that we could leverage, we as in the healthcare system can leverage to provide access, but we have to be intentional about it, because there is a double-edged sword, if you will, and that was certainly one of the lessons I learned as telehealth became more and more rampant and prevalent, is that if we there is a need to be aware and cognizant of how telehealth is leveraged and is offered so we don't exacerbate um, underlining health disparities in care and health disparities um, in those patients living in rural communities and those patients from disadvantaged populations. Because I think the pandemic, with the rampant uptick of telehealth, it shed a light, if you will, on a lot of longstanding issues in inequalities in healthcare. It shed a light on the fact that we could enable providers and patients alike to leverage telehealth, but some of the basics needed to be taken into consideration before that. So those patients in rural areas, they needed the appropriate bandwidth to be able to leverage telehealth while at home. Many of them still don't. And so what things do we need to take into consideration to make sure that we're addressing their needs? Perhaps enabling those rural hospitals to be a hub, for instance, to provide telehealth. And those are considerations that, unless we're intentional about, we could significantly, you know, exacerbate the digital divide, if you will. Similarly, in those poor areas, how can we provide access to care if we're leveraging mobile phones or mobile apps with those who may not have the ability to have internet, to afford internet access or afford a particular bandwidth that can sustain that meeting? So how do we go about addressing those issues such that we're not making that digital divide worse? I think that's really been one of the biggest lessons that I have seen.
Yeah, absolutely. Another challenge for us is, okay, so we were all forced to use telemedicine. The patients were told not to come in, and so we roll out whatever system that we had available. Well, now the big question is, okay, if the pandemic and the waivers start to subside, as well as reimbursement, then how does your healthcare system talk about um, the sustainability of these programs if they're not going to get paid for them? How do they weigh the benefit of, okay, this is really good for the patient and it's good for patient care, but we're going to lose money?
It's true. It's true.
Yeah.
And I think, ultimately it comes down to, in the pre-pandemic state, telehealth was slow to adopt for those very reasons. Those health systems that were both the payer and the provider, like the VA, have had this enacted since the 1960s, or Kaiser Permanente, where both they're the payer and the provider, or UPMC, the payer and the provider. Those have robust systems and robust programs in place, leveraging telehealth, but also showing significant improvement in patient outcomes. And so we've had the opportunity, as the general society, to experience some of those improvements in patient outcomes or improvements in care, because of all of those waivers, like 181 waivers, or something that have been put in place. And so I absolutely think the onus is on us as healthcare providers outside of being the payer and the provider, and those health systems that we're not, to really be able to have a collective voice to lobby, those in Congress to help them understand, provide the data that might be necessary to suggest there are improvements worth backing the equal reimbursement or the parity in reimbursement for telehealth, and a number of these waivers that need to be more permanent or sustainable. So I'm hopeful that if we have a strong collective voice, that will be enough to be able to provide that data to suggest that this is a better way, more cost-effective way in the general scheme of healthcare. It
Right.
helps with appropriate utilization.
It makes a lot more sense to have telemedicine be reimbursed than to pay for a plane to fly me to
That's
a
exactly
rural
it.
town in Rock Springs to see, 30 patients.
That's
Um,
exactly it.
and I would say to all the specialists that I helped get up and running and trained, when they were concerned about getting reimbursed, I said, you know what? See your patients and we'll ask forgiveness later. Like get
It's
started
true.
in doing it. And then the pandemic happened. The other thing that I would do is I would ask patients to get involved, send letters, and I have a
Yes,
letter that I would say, okay, here's the letter. Send this to Blue Cross Blue Shield and tell them your story. Call your congressman, your
absolutely.
congressperson. So Liz Cheney is our congresswoman, and she is co-sponsoring a telehealth bill for Congress. I don't remember the name of it, but I just sent her a letter a couple days ago thanking her for doing this. She is a believer in telehealth, so it's a bipartisan
Hmm.
positive.
Absolutely.
Yeah, and so this is the momentum that we need to keep pushing that wave so it goes through Congress to make these things permanent, these changes permanent.
I couldn't agree with you more. Absolutely. And completely agree that the patient advocate is strong, that voice, and we need to keep it. We need to keep it strong, and the providers as well. There has to be a better way to manage our ever increasing costs in healthcare, and this is one possible way. Exactly like you said, where we're asking for parity in that telehealth visit. So, where's the ROI in that? But it saves a significant amount downstream. If a patient is seeing an urgent care visit, instead of having to go to the emergency room and get, the multiple scans that they may or may not need, that's significant savings there. So there are absolute ways, I think, that we could look at a positive ROI.
Unfortunately, I'm going to play the skeptic here, is that our healthcare system is still fee for service. So the
Yep.
administrators who are worried about, the CEOs and the CFOs that are worried about the bottom line, they're still stuck in that model of bring them to the center and the clinic because that's where we make our money. And as long as that paradigm is front and center, and they're not forced to think about cost savings, but they're only thinking about how much money can we make. So, I say to them, your strategy is very different than the telemedicine champions. We say, bring healthcare to the patient, not the
Exactly.
patient to, the hospital. And it's
Yes.
hard to,
It is.
to
It
turn
is.
them around.
It is. I would say in oncology in particular, right? We have said there's a time and a place for what we call a hybrid model. There's a time and a place for patients to come on site, and there's equal opportunity for follow-up. Patients to be followed in the home, and that provides that continuous care, that wraparound care that really improves patient outcomes, improves patient satisfaction. So absolutely agree. We have a long road ahead of us,
Right.
um, but you know the possibilities are there.
The possibilities are definitely, it's just a very, very exciting exciting time. What are some of the projects that you're working on over the next year, let's say?
Yeah. So I would say one of the joys, this is definitely a exciting field for myself to be in, to grow, to create, to go back to what I had mentioned in the beginning, to innovate. So one of the programs that we are continuing to roll out very strongly in a pre-COVID state, we started it, is our rural health initiative, our rural health program. So we are partnering with rural community hospitals, rural health systems, and providing access to cancer care. So it's more than just we're providing that telehealth visit. We're really looking at that hybrid model. So we are providing the specialist, and we're working directly with an identified provider in the community. And we work in a triad model. So we see the patient in their facility, and at a particular interval, they come up and we get their scans, we get their staging, etc. We help with infusions that need to happen. So we're really collaborating with our rural health partners to make sure that patients, when they need to travel, they do, but they don't have to travel for every visit, and they can head to our rural health site as well. That's been fun. Another program that we've worked on is providing chemotherapy in the home. So for those who are eligible, clinical wise, their home environment wise, and for those who have, the appropriate medications with low side effect, to make sure that we ensure their safety, they're eligible to receive chemotherapy in the home with remote patient monitoring and telehealth oversight. And so we included that telehealth oversight and remote patient monitoring to really improve that safety profile. And that's been exciting as well. And then lastly, we're in the process of rolling out a larger remote patient monitoring program and care management. So there's a lot that there's a lot that we're doing.
Well, we need forward-thinking people, clinicians and doctors and pharmacists and every
It's true.
entity that can help in healthcare innovate and think of how they can how we can do better, in treating our patients, especially those that don't have access, to the care that they need, that are falling through the cracks. Um, is there any? Can you give us like an exciting patient story that sticks out in your mind with telehealth that you love to tell?
Absolutely, absolutely. I mean, I think of quite a few. Um, Back to a time when I was in Hawaii, actually, and like you, Lisa, we were flying in to the outer islands, to Maui or to Guam, um, to the outer islands in the morning, and then seeing patients all day, and then flying back that after that late evening, and that was our day prior to really implementing and really ramping up the telehealth. It's beneficial for all parties. And I recall a time when I was providing, endocrine service for a patient. We had many communications, many conversations over telehealth, and really helping this patient to streamline their medical care. This particular case, she was a diabetic, and we were doing a lot of diabetic teaching and recognition of symptoms, etc., and trying to improve her medication adherence. And this particular time, one of the challenges we were working with is she had significant hypoglycemia. And so I recall a time on the phone, I was speaking with her, and her husband was there, and we were trying to better understand if there's a pattern to her hypoglycemia so we can appropriately titrate her insulin. And I could tell that she was experiencing some issues. We had her check her finger stick, and I think her blood sugar was in the 40s, and less than 70 is critical. So at that time, her husband was just on that other call. I recognized the symptoms, and that she was going down. So we certainly had an intervention. I ended up calling 911, directing them to the across the island, which is not your typical, but directed them across the island, and the husband was there, and we were able to get an emergency glucagon shot while I was there on the phone, helping them to deploy that. So that was a significant case that I recall, just being able to provide that additional care, unexpected, that emergency care, if you will, for that patient. And I know there are some novel programs out there that are actually looking to leverage that visual aid or telemedicine visit for EMTs. So
Right.
it just provides an example of the benefit from that regard. That can provide. So
Yeah.
that's one of the things that stands out in my mind.
Do you incorporate with your platform? What platform does your health system use?
So we were on a different platform in the pre-pandemic state. Post-pandemic, we moved into MS Teams. It was just something that we were on already, and it provided an opportunity to quickly um, onboard many physicians and many patients. Without it wasn't too clunky, if you will.
Is that embedded in the EHR or is that separate?
Ours is separate. Ours is
Yeah.
separate at this point. And I know there are a number of initiatives, especially with Epic, to embed it directly into the EHR with, which is amazing. As long as you decrease the friction of the provider and the patient, you're improving the experience.
Yeah, I think, one of the things that we talked about also earlier today with our panel was physicians who have been hesitant, or let's just say resistant to
Yeah,
utilizing telemedicine because we're so traditionally trained that in their mind they're thinking, okay, well, this is just going to be temporary and then it's going to go away and then we can go back to our old habits. And, it's great to have the administrators and the teams behind the scenes saying all these fancy, fancy things. And I say to them, but guys, really the physicians just want this all to be easy, right? Because it's
that's
like
exactly it.
one more thing on their plate, they're not going to want to do it.
Exactly.
So, if it can be just a click from the medical records and that, it's easy for the patient and it's easy for the doctor. So, the speed that happened with the pandemic, I think everything's just going to start slowing down, and
Yeah.
um but my saying is we cannot go back.
I totally agree. I totally
Yeah.
agree. And part of that, to your point, is making sure that programs that have been stood up or implemented have processes that they put in place to make it sustainable.
Right.
Constant process improvement, constant kind of, re-engaging the provider, re-engaging the patient. Otherwise, it becomes just yet another clunky tool that they can't quite, overcome.
Right. It'll become another barrier, and another
Exactly.
reason why that. Yeah. So lots of exciting things moving forward. We're just in the middle of it. Um, we're gonna leave it there. If is there anything else you wanted to add?
No, I know. I think this has been extremely enjoyable, and thank you so much for having me.
Well, thank you for joining. It's been wonderful, and we're going to sign off. So see you later.
Okay,
Bye, Chevon.
bye now.